Yes, hello everyone, this is Dr. Khan, Executive Plastic Surgery. So this is a patient in her mid-60s from Texas with breast cancer on the right side. She had what was lumpectomy radiation back in '06. Then she had what was eventual reconstruction in 2014. And so she had history of latissimus flap, which is because of the radiation, they brought in the muscle and skin from the back and rotated it and basically reconstructed the right side with a latissimus flap. And she had 650 cc's on the right and 800 cc's on the left. And so as you will see, this is your latissimus flap. You can see the artificial nipple, and you can see relatively much thicker. And this was, remember, on the back, and it was rotated out. So all of this was removed. Remember, she is going to have what is an aesthetic flat chest closure. And if I may mention, this was your 2014 silicone implant in the standard fashion using alloderm and using basically what was significant amount of ethibond suture. So if you look over here, look at this. You have, look at this right here. This green, it's a braided suture. It's very thick. It was used to anchor in. And all of this suture with the scar tissue, granulation tissue, all of this was removed. Remember, that's part of the process. You can see how it winds around. I'm just going to cut this out so you can see, look how much extensive ethibond suture. And this is, you know, for me, I'm not a big fan of putting, obviously, I don't like to see what is ethibond suture in the proximity of the implant. And as you can see, this is suture right here, interwoven, the knots all the way extending from this side to this side. This was actually the superior side. Now as I go in and block the gold standard, I'm very happy and content. You can see this is part of the rib, by the way, right here, rib. This was sitting right on top of the chest, actually. This was superiorly holding this implant from falling down. You can see the alloderm, which is cadaveric skin. This belonged to another patient that they used for reconstruction. We'll see it from the inside. Ethibond suture holding the implant like literally like this on the chest wall. You can imagine how heavy this is pulling on the neck on this lady in their mid-60s. And you can see again, this is the cartilage part. In order for me to do this completely, definitively, sincerely. So as I go in here, let's go ahead and have a look. I'm going to actually go into the non. So look at this. I'm actually going to cut here. Look at this ethibond suture. So very nice, very good. So you can see the transition. Look at these streaks. And this is your alloderm, which is cadaveric skin. And you can see how it's folded up on itself. You see that? It was not anchored properly, and you can see how it's folded up on itself. And I'm going to go ahead and remove it. Look at this small amount of fluid. And it's, you know, if you look at it, I'm going to go ahead and you can see that fluid is all contained. And as I put it here, this is your 650, just like the operative note set, style 20. And look at these streaks. This is apparently what it is, another mesh that was used. And look at this cadaveric skin, the alloderm, biologic matrix that was folded up on itself. It's very hard. If I try to, let me show you. This is, remember, cadaveric skin from another patient that's been processed so that body does not reject it. If I try to cut it, I cannot. So I have to come close, and you can see now I can cut it. If I take my scissors, you can see how thick this is. And this is the scaffold, the reinforcement that's used. And I'm very happy and content with how the whole dissection has gone. Look, if I put the ruler here, how thin this capsule is. No matter how thin, this surgery can be done safely, definitively. I've heard some surgeons say, look at the mark that I put here. Obviously this transferred over. oh, the capsule was so thin I left it behind. No, you cannot say that. You have to physically remove it and remove all foreign body, ethibond, alloderm. So what I'm going to do now is I'm going to go ahead and put these. I'm going to focus on the left side. Now this is the large piece of mastectomy flap. This is your artificial nipple that was reconstructed. If I flip this over, I oriented at 12 o'clock, so we know this is the lateral, this is the medial, this is the lower part. And you can see how thin this flap was. So you can see right here. And so this is the prophylactic, left prophylactic mastectomy 800cc implant. And if you look, this is from 2014, so just 10-year-old reconstruction, just 10-year-old. Now, if you look at this arrow right here, here is what is a surgical clip. And I'm going to go ahead and remove it, and you can see right here, it's all encased. So all foreign material, including surgical clips, are removed. I'm going to give that to the patient so she knows. And again, you can actually see the boundary of the alloderm right here. Now, if I flip this around, you will see this is excess tissue, very hard inflamed. And this was underneath the muscle, and overall I'm very happy and content. So just 10-year-old set of implants. This is the better, nicer gummy bear, the cohesive implant. I'm going to go right at the boundary. I want to just show one thing. If I take my instrument and I put it right here, you can see how thin this is, right? You can see, look how you can see my scissors, right? If I take the back of the knife and I put it, you can see how thin this is. Obviously the alloderm is very thick, but you can see how thin this area is. So if I go in, look at this. Just 10-year-old set of implant. And this lady from Texas, 64 years of age. Look at this. Look at this cloth type mesh. I'm actually not, I don't want to cut that, so let's see on the inside. All done en bloc, remember the gold standard. Someone said, why do you have to do an unblock and everyone? Well, this is just 10-year-old set of implants. I'll tell you, this is why you do the en bloc. And as I let go, you will see this huge, the largest implant that they make. This is, you bet, the safer, better, nicer gummy bear, right? And look at all what was used in the reconstruction. You can see the mesh. And you can see the hurt that the patient was going through. Look at this. And I can literally tear it out. Look at the alloderm right here. You can actually see the hair follicles from the cadaveric skin, hair follicles. And I'm gonna just tear this out. Look at the mesh that was used for reconstruction and reinforcement. And you can see it all over here. Let me go ahead and remove it as well. I'll leave some of it behind. We saw it on the other side. So you can see again the alloderm right here. Look at again the hair follicles within, and this is like a nice piece. Very expensive alloderm. I'm gonna send it along with the capsule. So as you can see, I just want to go ahead and also highlight. Look at this one. Look at this green ethibond suture. I don't like what a braided suture. Imagine this is right next to cheese, if you will, and it's gonna cut right through it, right? You can see right here, right? You can see the heart knots, and right in the proximity of the implant, and you can imagine it's like rubbing against the implant, and it's going to cause it hurt. And you can see, look at the knot right here. It's very thick, braided Ethibond suture. Let me go ahead and look. The other thing I want to emphasize here is you can see some areas are so thin, as you saw earlier. So look at this. This is the nice, good, safe gummy bear implant. Absolutely not. They disintegrate just like the older ones. And this, the sad thing is this implant is just 10 years old. And you can imagine this didn't rupture yesterday. I do not know how long it has been ruptured. We cannot tell. Remember, according to the manufacturers, they want you to get a MRI at year 3, and then every 2 years they're onward to look for what is a silent rupture. You know, there are approximately 2 million ladies all over the world who get implants every year. So you can imagine 10 years ago how many ladies got the implants when they were safe, and how many ladies are walking around, and I would say millions who have implants who have ruptures and they do not know about it. And this is, if you do the math and statistically you look at it, you will only be alarmed that this is what's going on, unfortunately. And so the patients need to know, number one, warning from the FDA and the manufacturers, the implants are not lifetime devices. The longer people have them, the higher the chances are they're going to have problems, some of which will require more surgery. And the bottom line here is, if you have these devices, they need routine care, follow-up, imaging. If you look at the FDA recommendations, they say get an ultrasound at 5 years. You know, if you ask me, the ultrasound is sound waves. It's not as effective as the MRI without contrast, which is the gold standard to look for what is a potential rupture. And again, the goal here is that every patient needs to be aware that this is reality and that this is what is the course of the implants. I have removed implants from a patient several months ago, and 30 years later, they both were intact to my surprise. Now that can happen too, but remember, you require surveillance on a routine basis so that you don't want to deal with this problem and this eventually spilling into the chest. Yesterday I took care of a lady, 42-year-old set of implants. Both have been ruptured likely for decades, you know, and this is what no one should be going through, especially with the contracture and the silicone granuloma. So there you have it, end block, the gold standard, no other better way than this. This lady is going to have aesthetic flat chest closure, no need for the drains, complete removal in the manner that as you see. And this is what I would say 20 years from now, I cannot imagine anyone else doing the surgery any better, meaning any differently, any better, as far as removing the whole implant capsule, all inflamed tissue, all Ethibond, all surgical clips, no matter what the inflammation is. A patient will have the peace of mind that, number one, all of the implant capsule inflamed tissue is removed in end block fashion, and number two, all of it is going to be tested. So the implants will be returned to the patient. Capsules will be sent to pathology, rule out the PLLC, LCD30 analysis, that very rare cancer amongst the other cancer, including breast cancer. The right and left mastectomy scars will be sent to pathology. Cultures are going to be done for aerobic, anaerobic, and fungal. And there you have it. I just want you to show one more time. Look at this implant and look at this implant. This is not, look at the shell of the implant, how it's literally disintegrated. It is not gummy bear, and this is the same set of problems that the implants went through in the late 80s and early 90s before they were banned, and I think it will be only more appropriate if that were to happen sooner rather than later, so the ladies don't have to get hurt like this. This is Dr. Khan, Executive Plastic Surgeon.